specifically is the distinction between delivering ETAT as a short course and delivering it as a continuous process of quality improvement through which local clinicians are supported in their hospitals to develop the care practice that they're capable of. One of the things we've seen in our work in Sierra Leone, and I'll be very interested to hear what colleagues' experience around the room today is, but one of the things we've seen in Sierra Leone is a certain amount of tension between the delivery of the short course, the 3 or 5 day version of ETAT, which has certain benefits in the sense that it can be delivered as a compact unit. It controls the amount of resource requirement that's needed. It is easier, for example, for the Ministry of Health to deliver than for them to support the long course, which is ETAT stretched out over 6 months. And yet, I think what we find is that unless you embed the principles and the practices of ETAT, not just through a course, but in the daily life of the hospital, it doesn't have the kind of impact that we think it is capable of having. And so there is a question about how you mediate between the delivery of a technical course and the construction of ETAT as a quality improvement process, which incorporates all aspects of the care delivery system within the facility. And that, to me, is the key to this. When you look at the literature on ETAT, there is less which talks about that broader institutional and systemic context in which it needs to happen. I think this group is incredibly well placed with all the experience around the table. I think this group is really well placed to think through how we might want to advocate for ETAT, not just as a training course, but as a part of a much broader systemic quality improvement intervention. I'm going to leave it there, if I may. I just wanted to say welcome to everybody. Thanks for taking the time to do this. We very strongly believe that ETAT is an important contribution to the development of child health in low-income settings in particular, and we really appreciate your being here to keep pushing it along. Thanks.
Thanks very much. In a very non-technical way, I'm back. So we're going to move quickly to our first presentation, which is from Myanmar. For obvious reasons, we have worked hard to make sure that this is secure for the individual as possible. And so we've pre-recorded this presentation, which I'm now going to share with you. And hopefully you'll all be able to see it. I will put the link in the chat as well, in case you can't view it the first time round. But we're going to go first to Myanmar and listen to that.
This session is about Myanmar, and it's about ETAT Plus in conflict and how they are supporting the care of children now. In 2014, paediatricians in Myanmar approached the college, the RCPCH, as they had heard about ETAT Plus in East Africa and thought it might be adapted to suit their country. They realized that while there was some good care in the main city hospitals, the care available to children in small towns and villages was very limited. So we visited and agreed that with their help, we would adapt the ETAT Plus curriculum to fit their local WHO's facility-based integrated management of childhood illness, always called FIMNCI, and start running 5-day courses, as we had been doing in Kenya and Uganda. We called the adapted course EPCP, Emergency Pediatric Care Program, to avoid confusion, as there were minor differences in the content to comply with the FIMNCI protocols. Today, we're speaking with Dr. Moon, who was on our first course in 2015 and became one of our leading instructors from then onwards. In this interview, I'd like to first explore how she felt the introduction of the teaching in EPCP was received, and then how the quality improvement work developed. But as you all know, the situation changed radically in 2020 with COVID. And for Myanmar, far more dramatically on February the 1st, 2021, when the military staged a brutal coup. Dr. Moon has been an active member of the peaceful protest movement since the beginning, when many of professionals refused to work as part of the junta's regime. In response to this popular protest, termed the Civil Disobedience Movement, CDM, the military, in breach of international law, has waged a sustained assault on health workers. In 2021, according to the WHO, 40% of all recorded attacks on health workers worldwide were in Myanmar. And that makes it one of the most dangerous countries to be a doctor or nurse. As many of you will know, the RCPCH continues to provide significant technical support to doctors and nurses in hiding, including virtual technical support, protocols and training. And we remain committed to supporting our colleagues and friends at this terrible time. This interview has been pre-recorded for safety, and we're not using Dr. Moon's real name. She is in hiding, as are many of her friends and colleagues. Others have fled the country, and sadly, many are in prison on spurious charges. She will let us know how they are continuing to care for sick and wounded patients as best they can in these most difficult of all circumstances. We hope that she may be able to join us live for the question and answer session at the end. Dr. Moon, welcome to this ETAT Plus Summit. We're so glad you're able to take part and are keen to hear more about the situation for doctors, nurses, and your patients in Myanmar at the moment. First, I'd like to take you back to 2015, when you started your long and active work with the EPCP program. What do you remember about that first course in Mandalay, and how did it differ from the other teaching at the time?
Thank you, Jean, for giving me that chance to answer your question. As far as I remember, in 2015, I was one of the candidates of the first batch of ETAT course in Myanmar. I had attended some other international courses for APLS before ETAT as postgraduate student as well as junior pediatrician. But ETAT course is more interactive and structured course because it is simple and well designed for resource limited setting like our country, Myanmar. We could learn not only emergency care for children, but also teaching methods for healthcare providers and medical students. After this first ETAT course, we started training using this ETAT course format for our postgraduate students and medical students at the entry of their internship training in pediatric wards. We also arranged trainings for all nurses and junior doctors at OPD, outpatient department of our teaching hospital. Most of the candidates enjoyed ETAT course and they became more confident for emergency care in their wards. Thank you.
Over the next 3.5 years, we taught together in 4 regions of the country and in 23 hospitals. And in total, we trained more than 1,000 doctors and nurses in EPCP and almost 100 instructors. What difference did that make, do you think?
After over 3 years of ETAT training in district hospitals around Myanmar, we can obviously see that there was much improvement in referral system and the quality of staff from remote area. They are more confident enough for emergency care. In some hospitals, morbidity and mortality of under 5 children and neonates were reduced after ETAT course. We had well connected after this program, and we could provide some prompt advice to those who were working in that district or hospital. We can see the obvious outcome after the ETAT courses in those areas.
Then you and your Myanmar colleagues developed quality support teams to visit the district hospitals. And the idea about that was to help their quality improvement plans along the lines of the EPCP training. Would you tell us how those visits were set up and how they went?
We developed quality support teams and we visited to some district hospitals for implementation of the program. Most hospitals were much improved in layout of emergency care area by providing the visual notice for parents and attendants with ready first aid kit and system. Infection control was much improved in that area. And these are the very important to reduce the morbidity and mortality of our beloved children in those remote areas. We can imagine how much they improve after that ETAT courses.
What do you think the benefit of the team visiting, the QST team visiting, was in practice?
A QST team can give the advice and support which they are in need. And so they can learn from our QST team, and we can also learn from them, and we can provide what they need, and we can do to improve the care of the children in those remote areas. I think it's a very important step for successful of the DET program.
They kept people in touch with each other, didn't it? For mutual support.
We try to connect the staff from the remote area after our visit to those areas, and we became more familiar, and they are more confident to solve their problems with the help of our colleagues, and they usually follow the advice of the senior and the structure approach and the reference system.
Thank you. Sadly, things are very different now. COVID made life difficult, but I think you were able to support and maintain your support for the district hospitals throughout 2020, albeit remotely by Zoom. How did that work during the COVID time?
In 2020 COVID era, we tried our best to fight it with our available resources, with the unity of our elected government and people of Myanmar. We have to connect our colleagues from remote area virtually by using Zoom for training, and we had to overcome some difficulties during that COVID crisis.
What were the difficulties?
Because in some area, there is poor access of the internet, and most are not familiar with IT support. And so we have to give extra training for IT with the help of other friends who are familiar with IT things.
Yes. Now, for the last year, since the military coup on the 1st of February 2021, the situation has been much, much more difficult. I wonder if you can tell us what's been happening to healthcare in Myanmar, and in particular to you and your friends.
We thought that COVID is the nightmare for people, and especially difficult for our healthcare professionals. But in February 2021, we faced with another evil in Myanmar, which is more dangerous and cruel than COVID, that is military coup. It was the worst experience for us. We medical doctors and nurses became most targeted population by military junta for many reasons. First one is medical professionals in Myanmar became one of the strongest organizations against military junta, and those who had decided to do civil disobedient movement, CDM in Myanmar, to rescue our country. and we tried to save the lives of the people who were peaceful protesters during this emergency crisis. Another one is we were well connected and organized to set up parallel system for medical services for people and continuous medical education during this difficult situation. We tried our best during this revolution.
And now you're in hiding. What is your day-to-day life like?
This is the very difficult time for us, but we try to set up online and on-ground services for emergency medical care for our people, including COVID, non-COVID, and injuries related to violence. So me and my friends try to organize volunteer healthcare providers and give many online courses and some on-ground courses for our people with the help of our friends from inside and outside country. At the same time, we have to hide in the safe place, but it is very difficult for us.
When you need to see a patient, how do you manage that?
At first, we have to connect the local healthcare provider from that area, and then we can provide the services and advice through online. And we try to support these medical professionals by all means.
Do you see children yourself at all?
Because we have to hide in safe place, and it is very difficult for me to see the children on ground. But I try my best to give the advice for the children, and we try to connect the medical professionals on ground to give that service to the children.
Thank you very much. Is there anything else you would like to tell us about your situation now?
I'm sure we did a lot for our people during this difficult time. Although many nurses and doctors are killed, detained, granted with unlawful aid, many places where we give the care to our patients were destroyed and attacked by military junta.
Yes, we know that in many areas there has been a lot of fighting and even bombing around the hospitals. I wonder if you could tell those attending this conference how we can help you. How can we best advocate for your rights and offer you staunch practical and moral support?
Actually, we need urgent help from our international friends for funding, moral support, and technical support. Funding for supplies for humanitarian aid for IDP camps, because IDP camps are increased day by day. And we also need emergency drugs, and we need funding for the medical services. Another thing you can provide is the technical support for medical education, which are relevant during this revolution. And the last thing is the moral support for our CDM medical professionals. And we will be happy if you can provide the personal development program for our medical professionals, CDM. Thank you.
Thank you very much, Dr. Moon. We really wish you well. Thank you for telling us about your experiences, and all the best for the future.
So thank you very much, Dr. Moon. and just really, really grateful for your bravery in speaking to us today. We're now going to move to Liberia for our next session, and we have a presenter live with us. Mikey, it's over to you, and I'll share your slides in a second.
Hello, thank you very much for having me on here. So I'm really excited to be sharing about Liberia. We're very much, I guess, what I would call a sort of a baby program in a number of ways, in that we've only been doing ETAT in Liberia really for the last 2.5 years. So what I want to do is share some of the experiences that we've been through, some of the challenges, and a few what I think are sort of take-home messages of getting it off the ground. So my name is Mikey Bryant. Normal time, I'm the pediatric clinical lead for the ELWA hospital in Monrovia, Liberia. Right now, I'm back in Wales because our first child was actually born at 29 weeks very early, so I had to rush back for that. He's doing well, and in the coming weeks, we'll be back in Liberia again. But what's exciting is there is a strong core of local faculty who are keeping the ETAT practice going. So it's not in any way dependent on me being there or not there. And I also head up the Swansea Bay Africa Health Links charity there as well. And I'll put the next slide. So just to explain how it all got started, there's been a sort of long-standing link between actually Swansea and Sierra Leone. And in 2019, there was a request which came from the ELWA hospital to really have a proper pediatric program working there. And so seeing the success of Global Links and the strong kind of ETAT plus program that was working in Sierra Leone, it made a lot of sense for Swansea to begin to support a new initiative in Liberia. So initially, the first ETAT Plus course was very small. It was just part of a strategic under 5 healthcare initiative within the hospital, which included a small, at the time, very small integrated management of malnutrition project, pediatric emergency department, and little under 5 clinics. So it started life very small, essentially as a sort of a single center, very quick course. But what's happened in the last 2.5 years has been really exponential growth, where as success has been seen, a lot of partners have come on board, including backing from county health teams and the Ministry of Health getting involved, and then various NGOs, including Partners in Health, Samaritan's Purse, and also Last Mile Health, coming on board and collaborating with various ETAT Plus workshops and short courses. And what I also want to share about is, rather than just talking about the short courses, the actual journey to embedding some of this in practice. But in terms of those short courses, we've trained just over 300 people now through a total of 10 different workshops, and there's about 8 large centers who've had involvement. And then we have a local faculty, which is currently 10 Liberians and 6 international personnel as well. So it's a really collaborative effort. Keep going, next slide. And so just to say, our first training was almost like a pilot. It was essentially a 5-day course crammed into 3 days. We had fairly limited follow-up, and it was really just running in the ELWA hospital. But at the same time as the course, we were also doing a big initiative to provide medication and address some of the supply chain constraints being faced in the hospital. There were some successes and there were some challenges that came out of that, and a lot of lessons learned. See the picture there, that's our first group of people through the ETAT Plus training. Do the next slide, please. So really some lessons learned. I mean, the positives that came out of it were the benefit of a coordinated approach. So where previously, going back sort of as early as 2009, 2010, teams from Swansea would go out and do 1 to 2 week sort of short course ETAT and then fly home again. Having a continuous presence really over the last 3 years has meant that we've been able to actually address some of the operational challenges in the hospital as well. So dealing with some of the medication needs, actually providing a proper dedicated pediatric emergency department in the hospital, and then seeing an actual improvement in the way that triage is being done in the under 5 clinic. have all been very successful. So rather than just coming in, doing some training and leaving, we've been able to actually look at the outcomes. And really some of the feedback from the first short course was primarily that it was too short. Our second day of the course actually started at about 7:30, and we were still going well into the evening, and there was just far too much material. And one of the feedbacks that was actually presented to me almost personally was that some of the topics that we were presenting were not always very well understood. Coming in, perhaps myself coming in with almost this sort of fairly thick Welsh accent and things not quite getting across. And there were a couple of other challenges as well. Staff rotation at the time. When we started, there was a very small pediatric program. Staff were rotated in and out a lot. And also with us just at the start being in one center, it was obvious that some staff had been trained in slightly different treatment plans and protocols, some of which were a little bit off from the kind of ETAT guidelines. So actually to embed in practice was very, very hard after the first short course. So we learned a lot from that. It was very much a kind of a training learning experience for us. Maybe the next slide, please. So really the take home that came out of that was to look at really trying to find more, essentially more Liberian trainers who are going to not only attend the training workshops, but actually also become trainers themselves. And actually that has led to much, much stronger practice. So one of the sort of ways that we've gone about doing that in terms of identifying who are going to be our local, essentially our local trainers, has been firstly to look at how the various participants have done during the short course workshops, do assessments of that, but then actually evaluate in practice how this has been going, and just see how the various participants have been applying that. There's one thing to sit through an ETAT Plus workshop and to do all the right things in the practicals, but it's quite another to actually put that into practice in the pediatric emergency departments. Really, that was facilitated quite easily by having a continuous presence in the hospital, really, with the Swansea Bay participants, that'd be myself, and then various other people from different organizations actually working in the hospital day to day, seeing the training being put into practice, and actually identifying that. I've just had a message saying there's a problem with the sound. Can everybody hear me?
Yes, sounds fine from here.
Yeah, sounds fine. I think it's an individual problem. We're just dealing with it. Sorry,
We've got a fire alarm going off in the background here. I do apologize for that. Hopefully that will stop. So we do the next slide, please. Okay, can we have the next slide, please? Okay, so that meant that we had if we can go back one, please. Okay, so I do apologize for the fire alarm that's going off in the background. Please try to ignore that as much as you can. I don't quite know what that is. So just to say the second workshop that we did was actually some months afterwards, having taken on board such a lot of the feedback from the first one. And that meant that we actually had a much more successful course with a pass rate of 85%. And we actually had a lot more participants across several different centers. Really what had happened was essentially word had got out among many of the Liberian participants on the first course that actually the course was successful, that some of the implementation in ELWA was leading to lives being saved, and that there was a lot of good practice coming out. So from there, it was actually quite easy for a lot of other participants from different centers to start coming in. So we had people attending from as far away as Maryland County, which is all the way down in the south of Liberia. And two of those people who attended in the November course from Maryland actually became future ETAT Plus trainers and started running their own sort of mini ETATs and short courses and embedding those into practice down in the south of Liberia. So the feedback really from the second training course was that the material was much better understood. It was in much greater depth. There was a lot of much more positive feedback on the second one. So we were able to actually have a lot more success. And can I have the next slide, please? Okay, so really throughout 2020, it's quite obvious what happened. COVID-19 landed, but what was actually quite interesting was the impact of that on the pediatric healthcare system in Liberia. So just to give you some examples, our malnutrition program between April 2020 and July 2020 actually doubled in size. We actually had twice as many malnourished children showing up to the hospital, and it ended up throughout 2020 becoming a sort of a much larger project, 15 with capacity to expand up to 18-bed IPF, and then a large outpatient feeding as well. The reason for that being COVID-19 had a devastating economic impact on Liberia and led to worsening illnesses, worsening malnutrition. So there was a huge need for really high quality pediatric care going on. And so ETAT Plus, not only the short courses, but actually the principles became very much embedded into certainly ELWA hospital, and then starting to get into some of the other centers as well. The November 2020 course, we actually had over 60% of the material was delivered by Liberian facilitators. And we had the Deputy Minister of Health come and give the course's blessing. Very honored to have that take place. And we actually had participants from really all over Montserrado County, which is the county that the capital of Monrovia is in, as well as some visitors from all over the country, and very, very much identifying the sort of key pediatric people in each hospital. And that has led to, for example, if you go around the hospital in ELWA now, you'll see all the ETAT Plus posters are up everywhere. Most of the time we have a whole team of people there who are looking at compliance with the various ETAT Plus guidelines and tying that into mortality. And that has led to not only having the training courses, but also having essentially everybody speaking that same ETAT Plus language really throughout the hospital, all the way from the emergency department and the under 5 clinic up into the pediatric ward. So just trying the next, yeah, that's it. So really post COVID-19, we had a bigger opportunity to expand really as the focus has become less about the COVID-19 pandemic itself and more about the healthcare outcomes afterwards. So a couple of really exciting initiatives that went on in 2021. We were able to do a small kind of workshop to train some of the trainers down in Maryland, which is right down in the south of Liberia, to essentially allow one of the hospitals there, one of the government hospitals, which has support from Partners in Health, to become a kind of ETAT center, and then gradually identifying more and more sort of champions in each county. So our most recent course back in November actually had over 60 people, and from each hospital is represented. Various people are identified who essentially carry the knowledge back, and they do on the ward training with all the various people. And we had an additional Helping Babies Breathe component in 2021. Let's keep going. The next slide, please. Yeah. So just as there's some advantages, and I think this is the take-home message. Come back one, of the whole training and the whole principle of ETAT Plus is really when Liberian faculty are able to teach other Liberians, the content is very, very well understood. So what we've had increasingly is much more buy-in, much more people able to actually put things in practice because they're hearing it in a sort of vernacular and a language that they can understand very, very well. And really that's given us the advantage of tapping into a lot of the local networks. So for example, one of our ETAT Plus training courses, one of our physician assistants, who's one of our faculty, was able to essentially gain access into the hierarchy of the hospital that we're visiting and really promote ETAT Plus very well with the medical director in a way that me coming in as an outsider would not be possible. And also having a higher number of trainers. So I'll give you an example. One of our nurses who's become an ETAT Plus trainer works in the pediatric emergency department. And when new staff members come through, even quite highly qualified doctors, if they don't know the ETAT material, she will often go as far as adjusting their prescribing and fluid management and various things to get them into compliance with ETAT Plus. And she's become quite a sought after figure in the emergency department in terms of how to care for sick children. And it's also meant that we've been able to help and address gaps in the health system rapidly. So having a network of people throughout the hospital has meant that quite quickly, if we have a shortage of, say, our tessunate for antimalarials, that's escalated very rapidly and we're able to address that quickly. So really my take-home message is to have a wide network of well-trained local Liberian trainers who are able to sort of fan out across the various centers and actually deliver training. Next slide, please. So really just to wrap up, a couple of the challenges, still some ongoing issues. We've still got a lot of staff rotation. Various staff may sometimes be moved to other jobs. That's not always under our control. Still supply chain constraints. Often ELWA, we're very blessed really. We have a lot of NGOs who give us medicines and that helps, but other centers may not have that. So they may be taught the principles, but then they may only have, say, half of the medicines recommended on ETAT Plus. And really the other challenge, and we're working on this in collaboration with the family practice residency program that's been established in Liberia, is to have doctors and nurses and all the different professions on the same page. So we're really pushing that ETAT Plus is not just a nurse thing or a physician assistant thing, it's across all the professions. And as you can see, so far we're really a baby project. We've only got a very small faculty of people, and we do need to look at expanding that. And really our goals for the next 18 months are to essentially double the Liberian faculty. So just as I come into land, I'll have some conclusions. Do the next slide, please. Next slide. Yeah, so just a few conclusions. What I would say is the advantage of having more local trainers, I think that's been well stated, and also to say that this works. I mean, we track our mortality rates very, very closely in the ELWA hospital. We have some data from other centers, but we're not entirely sure exactly the exact figures on that. But we do know that the inpatient mortality dropped from 12% in January 2019 right the way down to 5% in November 2021. So we have had some real obvious success here, and it's because of essentially a combined strategy where rather than just doing trainings, we're actually addressing the underlying issues, the supply chain problems, overseeing the triage, making sure that the malnutrition program is well supported, and then actually making sure that there are a large network of Liberian people who are primarily driving this training rather than something being imposed from outside. This is very much a project which has ownership from the faculty, and really the faculty will be making a lot of the decisions about who they recommend to become trainers, who will be on the next courses. They'll be making recommendations about even things like the sort of design within each hospital and how to set up the triage. And those recommendations are followed. So it's very much become a local collaborative effort, really. And essentially, I'm really just facilitating and sort of managing and troubleshooting at this point. So Liberia is getting to the place where very, very soon, as we have more faculty, that there will be a lot of these courses kind of running all over the country and essentially running themselves. with a sort of ELWA hospital essentially as the ETAT hub, and the various other centres as kind of spokes out from there, really. So a lot of optimism for the future with ETAT Plus. We're seeing great results. And really the appreciation I have goes to our Liberian faculty, who are not only just sitting there as trainers, but they're working tirelessly day to day with the sickest children in the country and in the world indeed. So huge appreciation and respect for them and the work that they do. I know some of them are actually on the call now, which is great. So thanks very much for listening. I think I'll wrap it up there, and I'll hand you back over to our CPCH Global.
Great, thank you very much. And sorry, the slides took a little while to come through to you. They were coming through on our screen, but anyway. Deirdre, it's over to you.
Hi, everybody.
Hi.
I was given a completely different running order. There you go.
Sorry, I apologise for that. We just thought we'd mix it up a bit.
Excellent. Well, I am here with Timon from the German team to explain a little bit about the ETAT website that we discussed on the last couple of summits. It's very simple. The point of an ETAT website or an ETAT Plus website is so that this sort of collective networking can happen anytime, day or night. Any of you can join in, any of you can post. Lots of resources exist in lots of places. A lot of you have created handbooks, slideshows, policies, guidelines, ideas. And what we really want is people to share those and link up with people potentially in the same country, link up with donors, just sharing ideas. And while this is great to meet every 12 months, we need something on a daily basis. So we have a baby website that is just beginning, and Timon will show you some of the detail of it in a second. But basically each region, and they can increase as they are created, each region has a landing page on the home page, and that is where you can link to your resources, your own websites, your ideas. We need volunteers now from the group of people that are here and your friends and colleagues and family to volunteer to run your page. So to run your landing page, to be admins and to populate everything on it. We are not in a position to do that. This site is hosted by the German team. There's been input from the UK team so far, and a few other people around the world who are interested in the website. As you know, there's an app coming as well, which you'll hear about at the next meeting, if not before. But what I need now is an interested person or a couple of people from each of the regions to volunteer to be part of what I'm calling the ETAT Network Committee. So to pull the website together, to pull these summits together, and to see where we can go in our sharing of knowledge and information. If you're interested in volunteering for this work, and it can be as hard or as easy as we choose, or as each region chooses, I want you to contact RCPCH through the link that you were given for this talk, or through the invite or flyer that you were sent, and then they will filter you down to the rest of us. We will give admins and users support to learn how to use the site best and how to keep it secure and how to keep your information up to date. So now I'm going to hand over to Timon just to show you the opening design pages.
Yes, thank you very much for that introduction. I hope my screen is shared and visible right now.
Yeah, it's perfect.
All right, perfect, thank you. So as you can see, this is sort of where you start off with the website. And as mentioned, this is baby steps. This is starting out. The photographs are subject to change. And if you have any recommendations for both structure and design, feel free, obviously, to chip in. And so it just gives a brief overview of what ETAT Plus is about, and that this site is meant to be collaborative, and as just introduced to you. And it also gives a little heads up on how you may interact if you want to contribute to it. And that will lead you into a section which is titled Around the World, where you can see all these different branches and implementations and teams that work on ETAT around the world, and where they can each establish their own landing pages. And then as well, of course, you have a contributor login. You can search the site if you're looking for something specific, and there's also a forum for logged in users. And just to very quickly give an overview of once you actually have a login, we will send this out as well later on. You can quickly log into the page with the credentials provided to you, and you will then be able to add new posts to the site. And the beauty of it is that you can categorize these by the specific branch or team, meaning there's no confusion around who created it and for what purpose. That will also show up on an individual post. And these categories as well are quite important. For example, the one around the word you have just seen, that is featured prominently on the starting page. And that sort of gives the introduction to each and every single team or branch page. And as there will also be more detailed instructions, of course, for administrators, but that is once we have found out who is actually going to administer the page.
And that's it from the ETAT website team. As I say, our big shout out today is we want volunteers. We want people to engage with their regions or a region they know well's landing page to try and put all those resources and links and try and connect everybody together. Thank you all very much.
Great, thank you very much indeed for that, and apologies again for changing the order. Now for our next and final presentation, we recorded it because we weren't sure whether the internet would hold up, but I'm delighted because it looks like it has. So Dr. Kanu, and it's Nurse Abby? Nurse Abby, are you there? Can you hear us?
Yeah.
All the way over in Sierra Leone.
Yeah.
You're there. Wonderful. So I wondered if you'd like, great, excellent, fantastic. So I wondered if you'd be able to give us a little introduction to your film, and then we'll play it.
Okay, I am Abibatu from Sierra Leone. We were talking about the strategies after RCPs and deaths and our way forward. So how we are able to work and what we put together to work, because without global links, when global links left. So as the slideshow,
That's great, brilliant. Dr. Kanu, if you're there, I don't know. If not, don't worry.
Yeah.
Ooh, a little bit.
Yeah, sorry.
It's all right, no worries at all. Don't worry.
Hello, yes, I'm in the woods, so I'm okay.
You're there. Okay, perfect. We will come back to you for the Q&A, Dr. Kanu, and we'll try and work out what that terrible clicking noise is. I'm going to mute you for a second, if that's okay. Grand. Okay, so we're going to move, feeling incredibly vindicated at filming this beforehand. We're now going to move to the presentation that you guys did, which is great. So I'm just going to play your film, and then we'll go from there. Thanks very much.
Good day, everybody. I am Abibatu Samanaba, and my colleague is Dr. Abubakar Kano. We will be presenting about the ETAT sustainability in Sierra Leone, and I'll be talking about the sustainability strategies, while my colleague will be doing the way forward. So before going to the strategies, we want to talk about the statistics. So we trained both doctors and nurses in ETAT, and when RCPCH global links were here, we trained 2,546 candidates, and after the left, since last year, we've already trained 196 candidates nationwide, and including that, there were 4 faith-based hospitals that we are not under the Ministry of Health during the reign of global links, but now has come under the Ministry of Health, and we have trained 54 staff from these 4 faith-based hospitals, which gives us a number of total of 196 candidates. And also there are other courses, long courses that are ongoing in Odi stage and Okupa. We have 30 candidates in Odi stage and 25 candidates in Okupa. So these are photos from various units and various districts in the ETAT training. And for the sustainability strategies, we've been doing ETAT alongside GIC. So doing ETAT alongside GIC, we have candidates that did extremely well during the course, both in theoretical and practical sessions, and we call them the potential instructors. And after the ETAT training, we did a training for them, which is the generic instructors course, known as GIC, and we certify them as instructors. So when we have subsequent trainings in Freetown and in the provinces, we call them to be part of it. And they will be running both the short and the long courses. And also training the stakeholders as the Ministry of Health and Sanitation on ETAT and GIC. So I am Global Links. When they came at ETAT, we presented it to the stakeholders, the directorate in the Ministry of Health, and they reviewed it and they accepted it. They want to be part of it. So they are also being trained on ETAT and GIC as well. So also incorporating it into the undergraduate training. Before ASPIS were ramping up, they had a meeting with the Directorate of Trainings, the Director of Trainings, who happens to be the provost of the College of Medicine and Allied Health Sciences. We presented the topic, the ETAT to him. He reviewed it, scheduled a meeting, and he was so happy about it, and he accepted it, and even accepted incorporating it into the undergraduate, into the nursing training for both diploma and degree students, nursing students. So my colleague will talk about the way forward.
Yes, thank you very much, Abby. And so having discussed all of those successes, we are still challenged in a few areas which we consider as way forward. So to have an updated database. So once these trainings are ongoing in the districts, in Freetown, we currently have someone that is seated at Child Health who coordinates all of this, gets the lists, and then try to make sure that the certificates are printed so that we have serial numbers. But then we are challenged with top up and then stationaries in order to achieve this goal. And also, in order to, we also need a central team that will be doing the GIC training. So remember, during the sustainability, we identify potential instructors, and then we train them in order for them to become trainers also. So most of the team is based in Freetown, and we aim to be doing periodic refreshers training. So we will need this team to be sustained, so in order for us to have that central team, and we will keep on expanding it by training more GIC instructors. And also in the future, we are looking forward to incorporating it into the undergraduate medical student curriculum and the community health officers. Now it's only the nurses that have taken the whole ETAT syllabus. In med school, it's being taught in pieces, like triage is part of the training, but not the entire ETAT curriculum. So we intend for that to happen. And then, so what we plan to do is that they will do the full package during the undergraduate course, and when they come out, we will then do refreshers training, and we'll be doing that periodically as time goes on. So those are the things that we have for you. Thank you very much. The end.
Thanks very much, everyone. I think that's the end of the presentations. So we now have the Q&A session. There's been lots of activity in the chat, which is fantastic. It would be great if in the Q&A box you type your questions. Alternatively, if you wish to ask your questions, you can raise your hand and we can unmute you for that. I wondered if any of the panel would like to ask any questions just to start us off. Yeah, brilliant. Deirdre, you come.
Hi, I just wanted to thank all our speakers from the start, recorded or unrecorded. Particularly, I wanted to ask Dr. Moon, obviously you're facing unimaginable challenges at the minute. Most of us can't think about what it's like to do our job in hiding, what it's like to have our life threatened by turning up to work, or trying to help people. And it described beautifully how, trying to keep morale up is important, trying to keep training up is important. Referring back to what Seb said, is there an ability to collect data at the minute? Is there anybody on the ground that is able to measure some of the impacts and the effects that the military crisis has had on survival, on patient numbers? Because one of the things we're always asked for is data and proving the worth of the work we're doing. And I guess that's one of the things that's probably challenged really easily when things are under crisis. So it's, does anybody have a solution to keeping the information and the data coming through there?
That's a great question. Dr. Moon, I think you may want to talk, or you may want to write your answer in the chat or in the Q&A box is another option. If you'd like to do that, that's great. Of course, you can unmute your microphone as well if you'd like to do that as well. Jean, yeah, come on in there.
Yes, just to answer perhaps a little bit on Dr. Moon's behalf, if she's not able to speak now. We are aware that attendances actually at the established government-led hospitals are now very few and far between, essentially, that an enormous number of children are receiving care from healthcare workers with advice from doctors on the phone. We've heard again and again, we're working with hospitals in, at the moment, the Karen ethnic minority areas where the government writ doesn't completely run. And we hear time and time again that families would have an 8 or 10-hour journey, which is not only very long, but also not very safe. And that there's been a lot of bombing around the hospitals and in some cases of the hospitals. So I think our worry is that there really isn't any way of collecting data. So much is being done remotely, and we have been enormously impressed with the quality of some of the care offered by really very simple healthcare worker posts, with advice and help from doctors on the phone. But data is, I think, probably the first real casualty of the program.
Absolutely. We've got San in the audience. I'm going to unmute you, San, so you can continue with thoughts on that.
Thank you very much. I'm just answering on behalf of Dr. Moon. My name is San U. I'm one of the Burmese, but I've been living abroad longer than I live back home, and I have a privilege of going back home as a Global Link volunteer for 6 months as the very first group, ETAT group. And I just want to give you some idea that, the Dr. Moons and other healthcare workers are moving from safe house to safe house. So it's keeping the data is dangerous things. Even if you have evidence of anything in your mobile phone or in a paper form of anything, you'll be arrested there and then. And the arrest is not just arrest and thrown into the prison. That will be so much better for, that's my opinion, but they will take you to the interrogation center where you can die before you ended up in the prison. So this is one thing. And because it's been more than a year, the safe house are getting, the finding the safe house is getting more and more difficult for the peoples on the ground. That's, I know. So data, as Jean said, keeping the data is the last things that we could do at the moment. But if you think of as an outsider, so okay, we should keep the data to prove the quality, but that is not the case in Burma. Burma is unlike any other country, so I'm referring the country as Burma. It's my preference, but we are talking the same country. Burma and Myanmar are the same country. Okay, thank you very much. Thanks.
Thank you so much, San. That was really helpful. And yeah, I would say the data is very difficult, although there are multiple reports in terms of, whilst we don't, outcome data is very difficult. There are multiple reports of the atrocities that are being perpetrated on the health workers in Burma, Myanmar, and the Physicians for Human Rights Insecurity Insight, various other organisations have been involved in collating that data. And so if anyone's interested or wishes to lobby their government to argue for the protection of health workers in this situation, wherever you are in the world, then please get in contact with us and we can give you some data. As Jean said in her opening remarks, Myanmar is the most dangerous place at the moment to be a doctor or a nurse, and what is happening to the health workers there is appalling. And represents a real breach of basic decency and human rights and international law. We now have a question which I'm delighted about, and that's come in. So we've had a great question. My question is to Mikey. Please, could you tell us how you deal with staff trained in ETAT who are rotated out of the paediatric ward? Thanks. Mikey, are you able to answer that?
Yes, thank you. That's a really good question. So, I mean, sometimes there's not a lot you can do about it if staff are rotated out, and essentially you have to kind of restart and begin again. But what we've been able to do is develop a lot of very key relationships with the staff, particularly within the ELWA hospital. We've been able to develop positive relationships with some of the nursing leaders there. So we've been able to really present a case to say, well, actually, these are the trainers, these are the healthcare leaders, they shouldn't be moved out. And usually there's been a lot more buy-in. I mean, at the start it was very hard, but now that we have built relationship and there's trust between really the ETAT Plus faculty and the hospital, we're there in a good place. Now, where it becomes more challenging is when you have participants from other centres where we haven't yet built that relationship. Sometimes it can be very, very difficult in some of the particularly larger facilities where staff are rotating in and out every sort of 2 to 3 months. And in that case, really what you have to try to do is sort of meet with the local leaders and encourage them at least to keep a sort of a residue of some of those staff, at least within the paediatric ward or the paediatric emergency department, so people can rotate in and out and kind of learn from at least that residue there. But yeah, that's probably our number one constraint right now.
Okay, rotation of staff is, when I read that, I thought, yeah, that sounds very familiar because it's something that we deal with across our programs. Deirdre, you got your hand up.
I just wanted to maybe divert that question for a different answer, or an additional answer from Abby and Abu Bakr, because it was a problem in Sierra Leone about 6 years ago. And as far as I am aware, the solution was to negotiate with the rotation leads and the training leads, and obviously explain why keeping some expertise in each ward is actually quite important. But it was also related to how people were paid. So sometimes you have to look at the nitty-gritty of wages for midwives versus wages for nurses. And I just wonder whether Abby and Abu Bakr might have some more recent news from Sierra Leone on that specific problem.
Kindly go over the question, sorry.
It was, Abby, it was just to ask, when you train people for ETAT, but they rotate out of pediatrics very quickly, then you lose a lot of those skills. And when nurses were rotated from adult ward to pediatric ward to the ER to maternity every 3 months, that was a bigger problem. Then with the nursing school and the matrons there was a negotiation for people to stay in pediatrics for 6 months, 12 months during their nursing career. And that was a solution to that problem. And I'm just wondering what's the state of play in Sierra Leone with that at the minute, so you don't lose people to other jobs once you've trained them up with ETAT.
So yes, like you rightly said, that's what we used to do, and that's what we are still doing. Pardon me, I'm in the ward, so some background noise is ongoing. So that's what we are still doing. We engage the nursing team, the matrons, and right through to U building. We make sure that once they are trained, they stay in the pediatrics ward for a much longer time. And some of them they've not rotated for three or more years now. They've stayed in pediatrics ward. So we make sure they are retained. But yes, we do lose a lot of them. They have been posted to the medical wards and all this, but a huge chunk of them stay at least 6 months to 1 year, and some have stayed for up to 3 years in the pediatrics ward. So that collaboration between the heads of the hospital and the Ministry of Health and everybody is needed in order for the skills not to be lost. Thank you.
To add to what my colleague has already said,
Abby, carry on.
Most of them, some of them want to go for further their studies. That's why we do continuous mentoring and the continuous training. Whenever we have new staff, we train them on ETAT, and these in charges or these senior nurses that are going to do continuous mentoring, because they will have to go for study. Some of them, not like they are being posted out of the unit, but some of them want to go and further their studies. So that's why we do continuous mentoring to the junior nurse and students, and also the training continues for each new staff that comes to the hospital. We train them on ETAT for ongoing. And we also, as Dr. Kanu has already said, there was an argument with the CNMO and the matrons in the ward that we let the nurses be in the PED ward as not to lose the training they have already been taught.
Fantastic, thank you very much. Dij, do you have anything else to add there? No.
No, that answers that question. Great for me, thank you.
Fantastic. We've got another question that's come in, which was, thank you very much for your effort. I'm a general paediatrician from Syria working in Sudan, a country I know very well. My question is that, do we have a collaboration with the EU Resuscitation Council, the PALS Foundation in the US, especially in developing protocols? Who would like to take that question? Yeah, go for it.
I'm happy to take that on, yep. Marcus. Thank you for the question. Thank you for joining us. So I can speak on behalf of the UK ETAT group. Each country or each region's ETAT group develop their own protocols and guidelines, and they have different reference sources. They have different evidence bases that they use. But certainly from the UK point of view, there has been the EU Resus Council and APLS and PALS and ALSG are part of our evidence base. There is not a formal collaboration as organization to organization, partly because organizations like ALSG, who run APLS and PALS, are very huge, slow-moving organizations. Like the WHO, they will be very slow to change. Things like accepting the evidence from the FEAST study or the TRACT study, which is about blood transfusion in febrile children. Getting agreement across these big organizations to instigate new evidence-based protocols is incredibly slow and incredibly cumbersome. So in UK ETAT, we've tried to stay light on our feet, so be able to flex and change with new, robust, good data. So I would say that we would use these big organizations as reference points and evidence bases rather than a collaboration to try and get agreement so that all our guidelines are exactly the same. I'm also working with MSF at the minute, and they have their own guidelines as well, which again use a broader evidence base, and they take the bits that they have decided are valid, and they will leave behind the bits that they think are out of date or are too slow to move. I hope that answers your question.
Yeah, absolutely. Well, it wasn't my question, so I can't say whether it did or it didn't. But yes, no, I think that's yeah, that's it's interesting, isn't it, to see how those protocols and how things move. I pre-warned you about this on the chat, Jean, but I wondered if you're there. I wondered if you'd be able to say a little bit about the work that was done to align ETAT with FMI and CI. Maybe just explain a bit about what that is, because I think that's a problem that we're seeing quite commonly across a couple of countries, is this kind of melding together of two different things at the same time.
Yes, thank you, Marcus. I was a part of the group which started the negotiations with the Myanmar Paediatrics Society and indeed the Ministry of Health and Sport in the previous regime. And the message that we got was that there was already work going on with originally WHO's IMNCI, which is the Integrated Management of childhood and neonatal illness, and was being rolled out among the community services. And they were in the process of thinking about the facility-based version of that. And we had a very clear instruction that anything we taught must be consistent with the IMNCI protocols. This did mean a few really pretty trivial changes in the actual protocols, but we also wanted to come into line with the Myanmar Paediatrics Society guidelines, which had been very thoroughly developed in 2011 and then revised in 2018. So we kept in touch with them. However, the thing which ETAT Plus was really introducing was this very interactive, hands-on way of teaching. And Dr. Moon referred to that as being something that they picked up and ran with a lot, I think, in their particularly university-based teaching of medical students and postgraduate students. So the methodology was exactly the same as ETAT Plus. The precise details of the guidelines varied where they needed to, and they were really, on the whole, pretty trivial changes. But as you know, people get very upset if two teaching courses say slightly different things. So we were very, very careful. It was a terribly laborious exercise in the event, checking everything. But I think we kind of more or less did it. Thanks.
I'm laughing now. I don't think we were laughing then. Thank you very much for that. Yeah.
Sorry, Marcus, last thing, just to add to what Jean has said, because obviously we've worked together quite a lot. One of the things that, or one of the kind of founding concepts for anybody from a different region who's using ETAT is that we expect regional groups and teams to align the guidance with their national guidance. Or if they think their national guidance is out of date or is dangerous, to challenge it and to get it changed and to get it looked at. So it's not that ETAT is the law, ETAT is the guide, and you do always have to use it and teach it in the context of what your Ministry of Health, your Department of Health, and your medical schools and nursing schools are teaching. So alignment is really important. That's why it's important to stay flexible, stay up to date, and try and pull those two things together in whatever region you're in.
That's really helpful. And would you say that if you don't do that, you actually damage the institutions that you've just described? Do you think that's a risk?
100%, 100%. All the teams have talked about, and in the previous summits, people have talked about this embedding the teaching into the real life of the hospital, into the everyday work of the hospital. And you cannot do that if you are constantly disagreeing, constantly undermining Ministry, Department of Health, and the kind of a lot of the traditional teaching, even the teaching method. It's a really challenging thing to introduce ETAT to a lot of places, both the content and the style of teaching it. And then changing that into practice, it's really important that it belongs to the place that it's in and that it's not constantly criticizing the place that it's in. There's a sweet spot in the middle, isn't there? There's a way of improving things without making people feel bad and attacked and defensive all the time. And that's, I think, what's super important about that. And it's got to do with the wider engagement and buy-in of the concept. if you don't do that, if you walk into an organization going, this is rubbish and this is rubbish and this is rubbish, you're not going to last very long. And more importantly, you're going to make it very, very difficult, if not impossible, for the people who come after you, who also want to improve, develop, and change things. So not only are you failing for yourself and your own project, you are failing for anybody that comes after you. And I think that is the greatest tragedy of these situations, of not planning, not negotiating, and not engaging properly.
Yeah, absolutely. And we've Dickie, a long-term friend of the RCPCH, has put in the chat, very important point. Thanks. And I think that's right. And hopefully fairly soon, Dickie, when you get now up and running, we'll be able to have you on here presenting some of your work. I just encourage people to use the Q&A box at the bottom of the chat. We've got a couple of minutes left. While we're waiting for another question to come in, I wonder, Deirdre, would you just run through the point about the website again and how people engage with that? Because it's useful to have a reminder as we go on, isn't it?
Cool. So the website is essentially a gathering place. It is not intended to hold all the resources and the information from ETAT. It is a place where every ETAT team worldwide can contribute and can share their information. But each ETAT team needs to do it for themselves. There is not a core central group that can create this website. We have created the home of the website and the home page, and each group, each organization, you'll have seen a couple of sample questions or sample groups, like MSF do ETAT, so that's a group by itself. WHO do ETAT, so that's a group by itself. And so we need to populate all of these. When it is up and running, you can click on the home page, you go to, let's say, ETAT UK, and you'll click and there'll be links to the Royal College e-learning section. There will be links to the faculty handbook, the talks, the slides, the participant handbook. If you click on ETAT plus Kenya, you will get to their guideline book. You will get a link to their website. So it's not so much a replacement of anything, it's a connector for everything. So consider it a meeting room where we can all get together and we can share stuff. And in order to share, that's why we've put in the discussion forum, where you can find 2 or 3 people who are interested in the same topic as you. Then you can actually depart. You can go elsewhere. You can have a Telegram group. You can have a WhatsApp group. You can meet on Facebook. You can do whatever works for that particular subgroup. But this is essentially a meeting hall where we can all get together. But we just need everybody to help to build it.
Great, thank you very much for that. That's a real help. And just to add, we are currently in the process of putting all of the college's ETAT presentations will go up on the website. Megan and myself and others are going to be redoing our website again, which has been a bit neglected during COVID. So we'll be redoing that and putting more resources up in the not too distant future, which is great. We have no more questions currently. Some nice comments in the chat, including a discussion, the comment that's come from here, and I'm terribly sorry I don't read Arabic, so I can't see who you are, but thank you. Maybe discussion and education with local collaborators, with local authority will make a good change. I think we've identified that as a really important point in all of this, that strengthening and aligning with local organisations is the key to effective implementation. I think that's absolutely right. If there are no more questions or comments, I'm sort of looking around to see if anyone's got their hands up. If they aren't, I'm going to give people another minute to ask any questions in the chat. We've got about 30 seconds now. Okay, grand. On the basis that's it. Once again, panel, thank you so much for your presentations and your time. Thank you very much for the work that you are all continuing to do in differing and challenging circumstances. It's been really interesting to listen to ETAT from around the world. Really great that we're able to continue to meet in this way, and I think a really positive outcome from the pandemic, if such a thing is possible. And we hope that we'll do this again very shortly and hear from some more people about what they're doing and continue this momentum. Any other comments from anyone else? No, I'm shaking heads. Okay, we have no more questions, but we do have lots and lots and lots of nice things coming through on the chat. So have a quick read of those, and we'll close the meeting down in about a minute. Thanks very much, everyone. Stay safe.